Hello, doctors. Please let me know if you can hear me. Let me know if you can hear me. I just want to make sure that I'm also checking your comments on Facebook and YouTube. So please let me know if you can hear me. Let me know if you can hear me. Okay, please let me know. Let me know. I want to know whether you can hear me. So I'm also going live on YouTube just to check the interaction. So please, if you can hear me, just type yes. Awesome. Good. Thank you. I had to sort some things out, and so that's why I'm a bit late today. But look, as usual, we're going to study and get the ball rolling. Please do your best. Send this link to your friends in Facebook, WhatsApp, Discord, TikTok, wherever. Okay, tell them please join. And make sure that you're also sharing the YouTube link with them. Please make sure that you are clicking, you're subscribing, and then we getting the ball rolling. So I'm going to share my screen, and then we move from there. Beautiful. Let me see. Okay. All right. So please, can you see my slides as well? Can you see my slides, please? Can you see my slides? Please, can you see my slides? I want to know. Please, can you see my slides? Can you see my slides, please? Can you? Dr. Jagdeep, everyone, can you see my slides? Beautiful. If you can see my slides, that's good. I just want to make sure. Beautiful. Okay. So let's get into it because today's class is going to be very long. And for those in MedCognito as well, tonight you have a class in dermatology. Yes, I think you have a class in dermatology. So, this is just a prelude to that. So please make sure you are ready and you are prepared. Okay. So those in MedCognito, please kindly make sure that you prepare because you have two classes today. This one and the one for tonight. And so if you're also thinking that you want to join the dermatology class as well, kindly let me know after the lesson, and then we can make arrangements so that you can join that class. Okay. Secondly, if you're in MedCognito, please make sure that you've also completed all your dermatology modules before you go into the class so that the class will be easier for you. Okay. So welcome to today's class. Again, approach to pruritus. Let's get into it. As we do, I want to ask this question again. You will see one word is going through this over and over again. Itching is a common symptom. In the absence of primary skin lesions, generalized pruritus can be indicative of an underlying systemic disease. But itching in most cases is due to a cutaneous disorder. Why do you think the Medical Council wants us to learn this particular topic, especially from this one objective or this rationale? What is that one word? Doctors, please, I want to know. What is that one word? What is that one word? As you know, usually, what is that one word that we are seeing in almost all the objectives? In almost, I didn't say every objective, but what is that one word in almost all objectives, which helps us to know? Beautiful. Dr. Yvette, come on. Dr. Abiram, come on. Dr. Sabiha, come on, right? That is it. So it's a common symptom, and that is why the MCCQE1 will examine you on common stuff, right? Okay, good. So what are the causal conditions? The list is not exhaustive, but there can be skin lesions, there can be primary skin disease like blisters, dermatitis herpetiformis, psoriasis, lichen planus, scabies, pediculosis, eczema, allergic dermatitis, urticaria, arthropod bites, right? Factitious dermatitis. And it can also be that the person can have pruritus without the presence of any skin lesions. So people can develop dermatitis or pruritus because they have dry skin or because they're taking some drugs or some foods or obstructive biliary disease, right? Or even uremia, right? Uremia can cause you to itch a lot. And then kidney injury, and it could be due to, polycythemia vera as well, microcytic anemia, leukemia, lymphoma, carcinoid syndrome, diabetes, thyroid disease, psychiatric and emotional disorders. So doctors, the differentials for pruritus is endless. It's a lot. So you know what you need to do is, let me use this as an example of how to use this objective to study, right? So you come to the causal conditions and then you ask yourself, have I mastered dermatitis herpetiformis? Those in MedCognito and everybody, which GI tract condition is usually associated with dermatitis herpetiformis? Can you help me? Which gastrointestinal condition is usually associated with dermatitis herpetiformis? Please, I want to see your answer. So you see, if I were you, I would just list these causal conditions. I need to master dermatitis herpetiformis. I need to master psoriasis. Beautiful, beautiful, beautiful. Dr. Yvette, celiac disease. And I can see the MedCognito students. Celiac, 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 celiac. Beautiful, because we covered this in the celiac disease lecture, and we've also covered it in the Med Bullets as well, right? Med Bullets covers these things, these associations. So if I were you, I'll make sure that I cover dermatitis herpetiformis. I'll make sure that I cover psoriasis, lichen planus, right? Scabies will be covered. Pediculosis, I need to cover it. Eczema must be covered. Allergic dermatitis, you know, urticaria, factitious dermatitis. And I also have to know some drugs which can lead to pruritus. I need to know, you know, the complications of chronic kidney disease. I need to at least understand polycythemia vera. So if I go into my hematologic portal, I must look for that. I must know how leukemia will present, lymphoma, right? How diabetes will present. So you realize that with this slide alone, you have more than 20 topics to cover. And if you've not covered every single one of them, please don't move on to the other thing. That's how detailed we are in MedCognito. And so I told them that, look, now we even list the topics we do when we come to class. In February, we'll be doing a med drill in psychiatry. And the first class alone is going to cover 32 topics. You know, because we want to make sure, especially because of the change in the nature of the exam, that every single topic is covered. So we're going to cover in February med drills, psychiatry, 32 topics in 3 hours. Then we'll do another med drill. So by the time we are done in psychiatry alone, we'll have covered about 66 topics. That's how we do it in MedCognito. So please, I need you to really follow this. So if you're looking for what are the topics I need to follow so far as this particular condition is concerned, these are the topics. The MCC has given you the topics. Kindly follow them and make sure that you're getting the best out of them, right? That's all you need to do. Okay, so now let's move on. So the key objective is that given a patient with pruritus, the candidate will differentiate excoriations due to scratching from primary skin lesions. The candidate will identify skin lesions if present. So you should also be able to, if I should give you like various pictures, right? You should be able to tell me this is dermatitis herpetiformis, this is scabies, this is pediculosis, this is eczema, this is contact dermatitis. This, you should be able to do that. This is, you know, ringworm. This is that. You should be able to do that. Spot diagnosis, right? And in their absence, the candidate will identify the underlying cause of pruritus. Now, the enabling objectives. Given a patient with pruritus, the candidate will list and interpret critical clinical findings, including results of an appropriate history, including an occupational history, and a physical exam aimed at determining the cause of pruritus. So in other words, if I should quiz you alone on various causes of pruritus, and if we're supposed to do like an equation form class, like what we've done in some of our previous classes, and I give you this plus that, and maybe just show you a picture, you should be able to tell me, right? And differentiation of pruritus associated with skin lesions from that without primary skin disease, and any primary skin lesions associated with pruritus. Okay, now list and interpret critical clinical investigations, including investigations to diagnose systemic disorders in the absence of skin lesions, and construct an effective management plan, including providing local and other therapy for pruritus due to skin disease. 2, initiating a therapy for pruritus due to an underlying skin systemic disease. Number 3, initiating a referral for consideration of social issues related to infectious or parasitic causes, and referring the patient for specialized care if necessary, right? Doctors, so these are our enabling objectives. Now, before we get into the class, I just want to give you a little rundown of what is happening in MedCognito this week, because at times there's a lot of things or there's a lot happening. So tonight, we have a dermatology class. Tomorrow, for MCCQE1, tomorrow, we have the second part of the med drill in ethics. And remember that med drill is open to everybody. Whether you're a MedCognito student or not, med drill is open for you, right? Hematology and oncology will be happening on January 23rd. That is come Thursday. So every week, apart from the classes I conduct on Sunday afternoons, we also have classes on Sunday evenings and Thursday evenings. And depending on the med drill for that particular month, we also schedule something. So for the month of January, the MedCognito candidates said that ethics was a weakness some of them were struggling with. So they wanted us to do some extra classes in ethics. And that is what we are doing the med drill for. We did the first one. It is in their sprint portal. And then tomorrow, the second part of the ethics class will be taking place. Then on January 21st, that is on Tuesday, those taking the Narcoski class will be doing cardiology and respirology, right? And then therapeutic decision making for those who want to write their or who want to go into practice ready assessment will be restarting TDM in March 2025. For those who are already applying for CAMS and PRA in various provinces, MMI, CAMS, personal statements, preparation and one-on-one interview prep for PRA and CAMS is also ongoing. In fact, some people have some sessions today with our coach, right? So doctors, if you want to have a broad view of what is happening in MedCognito this week, this is what is happening, right? Okay, good. Another thing I want you to remember is that our book on communication is out. The Communication Guru is out. This one prepares you for the NAC-OSCE communication. It focuses on communication. On Friday, we sent out a first batch of people who needed a copy of these books. So if you want a copy, let me know. It's only $24.99. It will teach you everything you need to know so far as the communication bit of the NAC-OSCE is concerned. Communication, right? That's all you need to know. Okay, so if you want to get the book, it's $24.99. Is chicken change. We just wanted to make sure that you get it. In fact, I have some copies here. Let me show you. I have some copies here. So yeah, we sent out the copies on Friday. So if you want it, it will teach you how to build relationship with patients in a NAC-OSCE, how to understand the patient's perspective, how to fight the patient. All those things are in the book, right? So if you want it, that's also fine. You can get a copy. Now, what are the students saying? People are enjoying the class. Thank you for the tutor for another wonderful class. Concepts were well broken down. They had a nephrology class last week. Said that the nephrology class was very insightful and detailed with well-articulated notes after the questions, right? So now let's go back to the Pruritus and let's deal with some questions. Please make sure you have invited as many friends as possible. Invite your friends to join us so that we can all study together. At the same time, make sure that you hit the like and the subscribe button in YouTube so that we can, get this message to as many people as possible, and kindly do well to share with many friends. So look, what I've seen is that you guys have a trick. Most of the time, I introduce the topic that, oh, okay, today we're going to do, whatever, atopic dermatitis or something. And because of that, the first question I introduce, people go for that. So today I decided not to introduce the actual topic we are covering on the pruritus, and then we'll see. So let's go. A 23-year-old male presents the clinic with complaints of intense itching that worsens at night. He reports the itching started 2 weeks ago and has progressively worsened. On physical exam, there are erythematous papules and excoriations located on the webs of the fingers, wrists, axilla, and genitalia. What's the most likely diagnosis? Is it A, contact dermatitis, B, atopic dermatitis, C, scabies, D, psoriasis, or E, lichen planus? So what I've learned is that I'm not going to introduce the topic, because when I introduce the topic, people get it, and because of that, the first question becomes very easy. So what's the correct answer? Is it A? Is it B? Is it C? Is it D? Or is it E? So it looks like we have a lot of doctors going for God's favor. Ihioma Bright went for C. X or question mark went for C. Dr. Mehu went for C. And Dr. Mehu is saying that he is going for C because the question says that the patient itches at night. Interesting. Is somebody else going for something different? I don't think so. I think everybody went for C, and that is for a given. So the answer is C. The answer is scabies. So today's class is going to focus on scabies, right? So this patient has classic clinical features of scabies, including intense pruritus that worsens at night, which is with a characteristic distribution in the webs of the fingers, the wrist, the axilla, the genitalia. And usually with scabies, there's a confirmation of mites and eggs on microscopic examination, right? So one thing we need to understand is that scabies is caused by the mite Sarcoptes scabies, and it's highly contagious, especially in crowded living conditions. So these are some of the clues you want to pay attention to, right? Scabies is caused by Sarcoptes scabies and is highly contagious, especially in crowded living conditions, right? And usually you can find it in the webs of the fingers, the wrists, the axilla, the genitalia. And how do you confirm it? You confirm it with mites and eggs on microscopic examination. Okay, good. So why is contact dermatitis wrong? And the reason why I like teaching this way is because we can pick one question and then we can use that question because of the MCQ options to learn other things. So contact dermatitis typically presents with localized erythema and vesicles at the site of contact with an irritant or allergen. And the question did not really talk about that, right? And usually contact dermatitis lacks the widespread distribution or nocturnal pruritus. Please, doctors, write that down. Nocturnal pruritus, which is seen in scabies, right? Nocturnal pruritus, which is seen in scabies. Now, what about atopic dermatitis? Atopic dermatitis often involves chronic, relapsing eczema associated with a history of allergies or asthma. So that's also another clue you want to pick up. Is it that the patient already has a history of, allergies, a history of asthma? And it typically affects flexural areas, the elbows, the knees, and lacks burrows or mite detection, which is seen in scabies, right? Doctors, please. I don't want to move too fast. Are we okay? Are we okay? Contact dermatitis, does it sink in? Has it sunk in? Atopic dermatitis, and how you can separate that from scabies. And at the end of the presentation today, I'm going to show you pictures of all the differential diagnosis of scabies so you can be able to pick it up very well in your board exam, right? One thing we have to understand is that dermatology is also about a lot about spot diagnosis. So you should be able to see a picture and say that this is the diagnosis, this is the diagnosis, this is the diagnosis, right? Okay, good. What about psoriasis? So psoriasis usually manifests as well demarcated erythematous plaques with silvery scales. That's the word there. Silvery scales, and often involving extensor surfaces. Okay, it can be on extensor surfaces, it can be on the scalp, it can be on the sacrum. It does not cause the characteristic burrows or intense itching of scabies. So that's another thing with psoriasis. And lichen planus presents with pruritic, purple, polygonal, flat-topped papules, often on the wrists and the lower legs, okay? And it lacks the nocturnal pruritus. So you realize that it looks like nocturnal pruritus is something you need to really pay attention to when you are mastering scabies. So what are the summarized points or the summary points? Scabies presents with internal pruritus, intense pruritus, worse at night. The characteristic distribution is that usually it's in the webs, the fingers, the wrists, axilla, genitalia. And how do you confirm it? You confirm it with the detection of mites, eggs, or feces on microscopy, all right? And which people are high risk of developing scabies? People in crowded places or institutional settings, so like prisons, right? Long-term care facilities which are poorly managed, right? Maybe people who are traveling together, like, in a boat for a very long time. Maybe they are trying to escape a particular situation and they are all confined and one person has it. That can be. And then it is associated with Sarcoptes scabi. Next question. Next question. A 4-year-old boy is brought to the clinic by his mother for evaluation of severe itching that started 2 weeks ago. The mother reports that the itching is worse at night, and she has also developed an itching rash on her hands. On examination, the boy has multiple excoriations and erythematous papules, along with small linear burrows visible on the sides of the fingers and in web spaces on his hands. A skin scraping is obtained for microscopic examination. What's the best initial treatment for this condition? A. Oral ivermectin only. B. Topical hydrocortisone cream. C. Topical permethrin cream. D. Oral antihistamines. And E. Topical mupirocin. So what is our answer? Is it A? Is it B? Is it C? Is it D? Or is it E? And the correct answer is, it looks like everyone is going for it. So Dr. Mehu says that permethrin equals scabies. Beautiful. I like that. So the answer is topical permethrin cream, right? Topical permethrin cream. So, and I want to even go back. We learned in how to solve MCQ questions. If you don't know where to find it, go to our live YouTube videos. You see one of them there. And we learned something about, that word only, always, never. When you see those things in your MCQs, you want to be very careful. So oral ivermectin only. You want to be very careful about that. So what's the correct answer? Topical permethrin cream, right? This clinical presentation of pruritus, excoriations, and linear burrows and involvement of the household contacts is consistent with scabies, which we know, right? Topical permethrin cream is the first-line treatment for scabies, and is applied to the entire body from the neck down. And all close contacts should be treated simultaneously, even if they are asymptomatic, to prevent reinfestation. So, scabies is caused by Sarcoptes scabi in the webs, in institutionalized people, or crowded people. First line treatment is permethrin cream, and all close contacts should be treated simultaneously, even if they are asymptomatic, to prevent reinfestation. And what is the explanation for the rest of the answers? Oral ivermectin only. Be careful because of that word only, right? Oral ivermectin is effective for scabies, but is typically reserved for severe or crusted scabies. In the course of the class, you realize that we have two main types of scabies, depending on the immune state of the patient, or when topical treatment is not feasible. That is when you go for oral ivermectin. But in an MCQ situation, if you see oral ivermectin only, you want to be very careful. And this patient has classic scabies, which is best treated with topical permethrin as the initial treatment. Why is topical hydrocortisone wrong? Hydrocortisone cream may help to alleviate the itching, but it does not address the underlying manifestations by the mites, right? It is not a definitive treatment for scabies. What about the oral antihistamines, right? Antihistamines may also provide symptomatic relief, but it does not deal with the underlying issue, which is the mite infestation. Now, what about topical mupirocin? Mupirocin is an antibiotic cream used for bacterial skin infections, such as impetigo, and it has no role in treating scabies. So now, let's do a deep dive into scabies. So this is a picture of the Sarcoptes scabi, okay? And the organism which is causing the infestation. So we're going to do a deep dive. Doctors, please, are we all okay with the way we've gone so far? Are we all okay with the way the class has gone so far? Please, I want to know, are we all okay with the way the class has gone so far? We've just done questions. We are now going to do a deep dive into the introduction. We are now going to do a deep dive into introduction. Please make sure you are also telling your friends. Please subscribe to the YouTube channel. Subscribe. Please, doctors, subscribe now. Please subscribe now. Let's go. Okay. So what is scabies? Scabies is a skin infestation, and it is caused by the organism Sarcoptes scabi. The mites will burrow into the skin, and it causes itching and a rash, right? Now, I was talking to you about these two types of scabies, depending on the immune state of the patient, because I preempted you, right? The first one is the classic scabies, which is what we mostly see in our clinics, and when many of us are thinking about scabies, that is what we think about, classic scabies. And then the second part is the crusted scabies, or which is the severe form of scabies. Okay, so we have classic scabies, we have severe scabies. Dr. Isaac says what? Move on, kin. That's nice. Thank you very much. I'm a kin in your heart. That's beautiful. Because we are doing our best to make sure that we help as many people as possible, right? Okay, good. So now, classic scabies. So please remember, there are two types of scabies. Write it down. Two types of scabies. The organism is Sarcoptes scabi, right? The two types, the classic one is what we see. And the symptoms of the classic one are severe itching, especially at night, and a rash. Especially at night and a rash. And where are the common areas? The sides and the webs of the fingers, the wrists, the underarms, that's the axillae, around the nipples and the areola, and then genital areas, right? These are the areas, these are the places where scabies usually present. Now, I want you to learn how to remember the distribution of classic scabies. So I came up with this acronym. Fingers, wrists, axillae, genitalia feel really awfully itchy. Fingers, wrists, axillae, genitalia. They feel really awfully itchy. And I'll keep the acronym there, FRAI, F-R-A-I, F-R-A-I. That's the fingers and the webs, the wrists, the axillae, and they itch, and there's rash in the genital region. So F-R-A-I, right? Fingers, wrists, axillae, and genitalia feel really awfully itchy. So if you want to remember the distribution of classic scabies, that's what you need to know. Now, what about the crusted scabies, or the severe form? The crusted scabies is seen in patients with weak immune systems, right? Weak immune systems. So usually they are thick, crusty, and scaly with deep cracks. And with those people, you realize that the infestation is really, really heavy. So I'm just showing you a picture of a patient with crusted scabies. That's wild, right? So as soon as you see crusted scabies, think about crusty cracks in immunocompromised. That's also the way to remember it. Crusty cracks in immunocompromised or immunity compromised. And that's how crusty scabies looks like, right? Crusty scabies, or severe form of scabies. So how are we going to diagnose scabies? You confirm it by microscopic exam. And the microscopic exam will show you some mites, some eggs, and some fecal matter of the mites, right, on microscopy. But at times when you see the patient and you see the hands and those things, you can really tell that this patient has scabies. Now, who gets scabies? Because we are trying to learn the principles so we can be able to ace our MCQ1 exam, right? People in crowded places, so long-term care facilities, prisons, you know, it is more common in resource-poor areas. So if you want to remember it very well, please write this down in your book. Write it down right away. Scabies loves crowds. Scabies, it loves the crowds. So that is one thing you want to use. Long-term care facility, prisons, scabies loves crowds. And this is just a reminder of the Medro, which is happening tomorrow. We've done the first one on the 8th of January, and we'll be doing another one tomorrow on the 20th of January. This is my special time with MedCognito students, right? Where we go through everything. And you don't even need to be a MedCognito student. You can still register with this link For those in MedCognito, you don't need to register. You'll be sent the link right away. So that's what someone said about the last med drill. Thanks a lot, Dr. Brody. The course is well structured and a lot of motivation and encouragement from your side. Med drills are awesome. Love that class, Dr. Brody. So now let's go back to transmission of scabies. Transmission. How is scabies transmitted? So let's deal with the question here. You have a 45-year-old man who presents to the clinic with complaints of intense itching that worsens at night. He mentions that his symptoms started 2 weeks ago, shortly after moving into a shared apartment with 3 roommates. On further questioning, he reveals that one of his roommates has similar symptoms and they frequently shared a couch. On examination, there is coriated papules on the man's fingers, wrist, and abdomen. What's the most likely mode of transmission in this case? A. Casual skin contact with his roommate. B. Prolonged skin-to-skin contact with his roommate. C. Transmission from a household pet. D. Sharing of fomites. For example, like couch, clothing, clothing and bedding. And then E. Inhalation of airborne particles. What's the correct answer? Is it A? Is it B? Is it C? Is it D? Or is it E? In other words, this question is basically asking you, what's the commonest way that scabies is spread? Is it casual skin-to-skin contact? Is it B, prolonged skin-to-skin contact with his roommates? Is it C, transmission from a household pet? Is it D, sharing of fomites? Or is it E, inhalation of airborne particles? For those who are sharing their answers, you want to ask yourself, I see a lot of people going for D, D, D. And I know that they are looking at this particular man. He shares, but is that the easiest way that scabies is spread? Is that the easiest way? The answer is B. In fact, the answer is B. And what do I mean by that? Scabies is primarily transmitted through direct and prolonged skin-to-skin contact, such as that which may occur among family members or roommates. Okay, this clinical presentation of intense pruritus, wears at night, and distribution involving the fingers and the wrists is characteristic of scabies infestation. Now, why is D wrong? Many people chose D. Fomite transmission is rare. It's a rare form of transmission, as the mite burden is typically low. So it could be that, yes, they were sitting on the same chair and all those things, but the primary easy way that scabies is spread from person to person is ongoing contact, not casual, but prolonged contact. So doctors, that was the way the question was tricking you. So one thing we need to understand is that when we share the couch and clothing and bedding, yes, it's a way that scabies can be spread, but it is a very rare form. If you like, you can check up to date and it will tell you the same thing, right? It is more commonly associated. It is more commonly associated with crusted scabies, which this patient does not have. So one other thing you have to understand is that for patients to get the form of scabies, which is spread by the use of the couch, clothing, or bedding, usually that patient should be immunosuppressed. That is it. Usually. So two things. It is rare. Getting scabies through fomites is rare. Number two, for people to get scabies through fomites and sharing of clothes and bedding, usually the person who is getting that infestation has some immunosuppression going on. Okay. Now, transmission of scabies. So let's do a deep dive into it. Direct and prolonged skin-to-skin contact is the most common way. Okay, it happens among family members. It happens among sexual partners. Casual contact like handshakes is unlikely to spread scabies. Casual contact like handshakes is unlikely to spread scabies. What about through objects? It is rare in classic scabies because these objects like the couch and the rest, they have low mite burden. Most of the time, if somebody is going to get scabies because they shared, a fomite with somebody, it is more likely in crusted scabies. I think I've already said this, but I want to repeat this. So like clothing, bed clothes, personal items. So if somebody is going to develop scabies as a result of sharing a couch with somebody else, or as a result of wearing someone else's clothes, chances are that that person who has developed the scabies has some immunosuppression. And somebody wants me to go back to the previous question. And the previous question is this: a 45-year-old man presents to the clinic with complaints of intense itching that is worsened at night. He mentions that his symptoms started 2 weeks ago, shortly after moving into a shared apartment with 3 roommates. On further questioning, that he reveals that one of his roommates has similar symptoms and they frequently share a couch. That was just a red herring. That was just something to take you off course. Because the truth is that if you learn scabies very well, you don't easily pick up scabies from the couch. That's all I'm trying to say. Okay? On examination, there is coriated papules on the man's fingers, wrist, and abdomen. What's the most likely mode of transmission in this case? Remember, this man does not have, any immunosuppression. Let's always remember that immunosuppression is what makes getting scabies from the couch and the rest more likely. So if you get a patient who says that, oh, I don't have any direct contact with anybody, but I still develop scabies, you want to start thinking, does this patient have some immunosuppression of a sort? All right? Okay. Now let's go on to the next question. You have a 70-year-old male with a history of AIDS, advanced AIDS, presents with widespread scaling, crusting, and fissures involving his scalp, his hands, his feet, and his trunk. The lesions are maladrous. That means they smell bad. And his nails are thickened and discolored. He denies significant itching. On further questioning, the patient reveals he has been using topical corticosteroids for a chronic skin condition. Skin scrapings show a high mite burden. Was the most likely diagnosis: A, psoriasis; B, crusted scabies; C, eczema; D, tinea corporis; E, contact dermatitis. What's the correct answer? So it looks like a lot of doctors are getting this one right. Dr. Paramita got it right, B. Dr. Jagdeep also got it right, B. And the correct answer is B, crusted scabies. So crusted scabies is the same as, the worst form of scabies, which happens in patients with immunosuppression, right? These patients exhibit classic features of crusted scabies, including widespread erythematous scaling and crusting, and thickened and discolored nails, and minimal pruritus. Crusted scabies is often seen in immunocompromised individuals, such as those with advanced AIDS, and in patients with prolonged use of topical corticosteroids. And the high mite burden confirmed by the skin scraping further supports the diagnosis. This is simple, easy peasy. Let's move on to the next thing. So psoriasis was wrong, eczema was wrong, tinea corporis was wrong. Usually tinea corporis will present with a circle scaly plaque with central clearing, right, and peripheral scaling. It does not produce crusting, it does not produce fissuring or taking nails. This gentleman has advanced HIV, and that is why he's having these symptoms. Okay. So, now let's look at the clinical manifestations of these two types of scabies: the classical scabies and the crusted scabies, the clinical manifestations. So, when you take a patient with classic scabies, the main symptom is that they have intense itching, and it is especially worse at night. And the cause of the itch is because of delayed allergic reaction to the mite, their eggs, and the feces. What's the timing of their symptoms? So usually they get the infestation first, and the symptoms start 3 to 6 weeks after they are exposed, right? So you don't just develop scabies just like that. It is about 1 month to 1.5 months for you to develop it. Now, symptoms appear within 1 to 3 days due to prior sensitization if they are getting reinfestation. So if you have a patient who is now developing scabies afresh, never had scabies before, it will take about 3 to 6 weeks. But if the patient has had scabies in the past and they are getting reinfested, so maybe the patient is in a prison or something and they were treated, but then they are developing the infestation again, usually to take 1 to 3 days. And what are the skin findings? You see some small red bumps, which are like the erythematous papules, and I described them in the previous questions. Often they are excoriated, and then you see the burrows. They are thin, wavy lines. Okay, they can be gray, red, or brown. And you can also see other skin lesions like mini wheals, vesicles, pustules, and rarely some bullae, right? And what are the common areas that you can see scabies? You can see it in the fingers, you can see it in the wrists, you can see it on the elbows, extensor surfaces, on the underarms, right? On the chests, perioral skin, especially, or periareola, sorry, especially in women, right? Belly button area, so around the umbilicus, in the waist, because like they may be put on their belt around that area. Male genitalia around the scrotum, right? In the shaft of the penis, the glands, as well as some extensor surfaces on the knees. Doctors, this is very important because I've said this. The exam is changing from CBM and MCQs to MCQs alone. That means that you must master some details. So, for example, don't just learn scabies as scabies. Where on the fingers will scabies present? In the webs and on the sides. When you take the wrists, where is it? On the flexor surface, on the extensor surfaces? When you take the elbow, so someone can easily confuse you in an MCQ, with some of these things, and that is why I've taken my time to break these things down for you. What about the underarms? What about the male genitalia? Where exactly around the male genitalia can you see scabies? Right? These are the things I want you to know. Buttocks, is it on the upper part or the lower part? The feet, is it on the lateral or the posterior aspects? These are the things I want you to start focusing on, because you are going into an MCQ exam. Like this slide alone, if I am supposed to quiz you on it, it can be crazy, right? Because I can say, the following are common areas that scabies can occur. Flexor surfaces of elbows. And then, the one who is not really learned very well will be confused. And that's why I'm taking my time. So please, take your time. This slide is very important. I'll take my time. If you want to write it down, write it down. When you are done, tell me, I will move on. If you are done, let me know. Just type yes, 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 I'm done. Or if you want to take a screenshot, whatever, let me know, and then we'll move on. Please, when you're done, let me know. Whether you took a screenshot or you're writing the notes or whatever, let me know, and then we'll move on. Because for me, this is very important. This is very important. Common locations of classic scabies presentation. When it comes to the male genitalia, where is it? When it comes to the knees, where is it? What's the difference between the way it presents on the knees and the way it presents on the wrists in terms of distribution? Right? Okay, good. So classic scabies, you want to in children and in infants, the rash affects the palms, the soles, and the fingers, all aspects of these places. Lesions are more inflamed in children. Okay, and then we also have a form of scabies, which is the nodular scabies. Usually it is persistent, firm, red, itchy nodules. It is common in the groin. Doctors, please, this is also a very important one. Common in the genitalia, common in the buttocks area, common in the underarms, right? And it represents a hypersensitivity reaction. So, know the distribution of classic scabies. Know how classic scabies presents in children. Know something about nodular scabies and its common areas of presentation. Okay, what about crusted scabies? Remember, crusted scabies is found in the patients who are immunosuppressed, right? It's also known as Norwegian scabies. It's also known as keratotic scabies. Now, who gets crusted scabies? People with weakened immunity, such as those with HIV, HTLV1 infection, right? Leprosy. So please, these are things I also want you to pay attention to. Who gets crusted scabies. Which group of people? HIV and AIDS, HTLV1 infection, leprosy, lymphoma, patients with Down syndrome, as well as elderly patients or patients on long-term topical steroids. These are the classes of people who get crusted scabies. Please, I want to pause here. If you want to take notes, let me know. This is also very important. Crusted scabies, because we learned immunosuppressed, but who, like, you know, what are some forms of immunosuppression that I need to know about? Lymphoma, leprosy, HTLV infection, you know, HIV patients and other patients with like Down syndrome, and especially elderly patients or people with long-term topical steroid use. Okay. Now, I will make a point later on in the class, but remember that we don't need laboratory investigations to diagnose scabies. You can tell that this patient has scabies. However, if you should do blood work for a patient with scabies, right? If you should do blood work for a patient with scabies, usually you will realize that they will present with eosinophilia, elevated eosinophil levels, and high IgE levels. Let me say this again. You don't need laboratory investigation to diagnose scabies. There's a slide which is coming, which will talk about that. However, if you should do a laboratory investigation, the patient will have eosinophilia and the patient will have high IgE levels. All right? Okay, so now let's deal with the question. A 9-year-old boy presents with intense itching and erythematous papules, predominantly in the web spaces of his fingers, wrist, and axillae. His mother reports scratching has led to areas of oozing and crusting. On examination, there are excoriated lesions and small pustules. A few weeks ago, he was diagnosed with scabies and was treated with permethrin cream, but symptoms have not resolved. What was the most likely complication in this patient? A, atopic dermatitis. B, secondary bacterial infection. C, post-streptococcal glomerulonephritis. D, crusted scabies. And E, contact dermatitis. What's the correct answer? Is it A, is it B, is it C, or is it D? Beautiful. Dr. Isaac went for B. Dr. God's favor, please check it again. Why are you thinking about crusted scabies? Which group of people develop crusted scabies? Right? Which group of people develop crusted scabies? Crusted scabies is seen in patients who are immunosuppressed. Right? This is a 9-year-old boy. Intense itching, erythematous papules, predominantly in the web spaces, if you remember. His mother reports scratching has led to areas of oozing and crusting. On examination, there are excoriated lesions and small pustules. Pustules, so pus containing areas. Pustules, pus containing areas. A few weeks ago, he was diagnosed with scabies and was treated with permethrin cream. And when we get to the management, you realize that, in fact, patients with crusted scabies, we don't even treat them with permethrin cream alone. Okay, but symptoms have not resolved. So I have a question. You have somebody with scabies, you've confirmed it, but then you've treated and now the patient has been forming pus in the areas, pustules. Okay, what's your diagnosis? This is secondary bacterial infection. The patient has developed secondary bacterial infection. So secondary bacterial infections such as impetigo, eczema, or furunculosis are common complications of scabies. Okay, they occur due to the scratching, which compromises the skin barrier and provides an entry point for bacteria, primarily Staphylococcus aureus and Strep pyogenes. So this patient has scabies, all right. He was given topical permethrin cream, but because of the scratching, it gave way for staph to infest and that is why the patient now has these pustules, right? So the answer is B, 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 B. Dr. Sabia, is not D, it's B. All right? Okay. So, crusted scabies. Remember that we said that crusted scabies is seen in immunocompromised individuals. That's the main thing you need to remember for your board exam. Crusted scabies, immunocompromised individuals. What about post-streptococcal glomerulonephritis? It's rare. Even though it's a complication of scabies, it's a rare complication due to the secondary infestation with streptococci, right? So while streptococcal infections secondary to scabies can lead to this complication, the patient does not exhibit signs of hematuria, edema, hypertension, which is associated with post-streptococcal glomerulonephritis. So it is not post-streptococcal glomerulonephritis. So what are the summarized points here? Secondary bacterial infections in scabies. Common infections can be impetigo, ecthyma, furunculosis. It is caused by Staphylococcus aureus and or Strep pyogenes, right? A complication which is rare is post-streptococcal glomerulonephritis, and it's not as a result of the scabies itself, but it's as a result of the secondary bacterial infection. And usually, if you see a patient with post-streptococcal glomerulonephritis in your board exam, you have to look out for that patient who developed a skin infection and then has gone on to develop hematuria, has gone on to develop edema, has gone on to develop hypertension. These are the things you want to pay attention to. So, back to the complications of scabies, there can be secondary infections, secondary bacterial infections, streptococcal complications like post-streptococcal glomerulonephritis, and generalized urticaria. Okay, so the secondary infections, we've already talked about them. It can be due to Staphylococcus, it can be due to streptococci, right? And impetigo is one of them, ecthyma is one of them, which is a deeper skin infection with ulcers. There can be paronychia, so on the nail bed and the nail. It can be furunculosis, which is boils, right? Crusted scabies increases the risk due to fissures that allow bacteria to enter. And we know that crusted scabies occurs in patients who are immunosuppressed, like HIV, like lymphoma, like HTLV1, and other patients like patients with leprosy, elderly patients, or patients who have used topical steroids for a very long time. That is crusted scabies. What about the streptococcal complications? I've already talked about it. But streptococcal infections can cause post-streptococcal glomerulonephritis. That is, kidney inflammation. And that can lead to hematuria, hypertension, edema, right? And there is a protein in the scabies mite, which is SMSB4, which may increase the risk of secondary streptococcal infection, which then leads to the post-streptococcal glomerulonephritis. But this is too highfalutin for MCCQE1. I just brought it in as a teaching point. There's no need for you to worry yourself about SMSB4, protein. There's no point worrying yourself about that. And then generalized urticaria, it can occur. And it's as a result, it can sometimes be the first sign of scabies. And we've learned that when patients develop scabies, it takes about 3 to 6 weeks for you to see manifestations of the condition. However, if they've developed scabies before, then they can develop the symptoms, usually within 1 to 3 days. So how are we going to diagnose scabies? Doctors, please, before we move on, how has the class been so far? I want to get your feedback. How has the class been so far? Is it helpful? How has the class been so far, please? Is it helpful? Has it been helpful, please? I want to know. How has the class been so far? Has it been helpful? Good. 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 Okay, so Dr. Stella says amazing. Dr. Miriam says yes. So if it's amazing, what has made it amazing? I want to know. What has made it amazing? What has made it amazing? And are you getting a grasp of the concept very well? a better grasp of the concept. That's what I'm trying to do. So if when you hear candidates say that the med drills was powerful, like the classes are great, this is how we conduct our classes, right? This is how we conduct it. We really want to make sure that you grasp the concept very well. This is how we conduct our classes, right? Okay, good. So how are you going to diagnose scabies? Let's go for a question here. So you have a 52-year-old male. This doctor says what? One of the best decisions I made was subscribing to MedCognito. Thank you, Dr. Bruni. I remember hearing your voice in my head during my exam. That's Dr. Smart for you. Yeah. Dr. Smart did very, very well in his QE1 exam. I think 260 something? And he still counts for QE1 classes anyway, even though he's passed it, because it's just the knowledge we are building, right? He got 260 something. So if you want to ask him how he did it, you can ask him. Right? That guy he called Smart, and he did very well. That's his name, Smart Agedoike. He's Nigerian. Very, very well. Very, very well in the exam. And I'm happy he still comes for like these lessons, because these lessons are not just for those who are writing the exam only, right? It also prepares you. So please, do you see my screen? I want to go on to this question so we can go on. Okay, so we have a 52-year-old male who presents a 2-month history. So that's the guy. If you want to, if you can contact him. Very great guy. Did very well in his QE1. I think he scored more than 260. I think so. So I have a 52-year-old man. I think I shared his comment. He says one of the best decisions I made was subscribing to MedCognito. Thank you, Dr. Bruni. Yeah, okay, good. So a 52-year-old man presents with a 2-month history of intense nighttime itching and erythematous papules on his hands, wrists, and abdomen. His symptoms started 3 weeks after returning from a trip to a crowded hostel. On examination, multiple excoriated papules and burrows are noted in the web spaces and his fingers. A scabies preparation using a skin scraping from his wrist fails to detect the mites, eggs, and feces. What's the most appropriate next step in confirming the diagnosis? A. Perform a biopsy of the affected skin. B. Conduct an adhesive tape test. C. Repeat skin scrapings from additional sites. D. Perform blood tests for eosinophilia. E. Diagnose clinically and start treatment. So Dr. Sabiha also says, while we answer this question, he says your lecture is easy to understand. That's good. Thank you for that feedback. And then Dr. Farah Khan also says that the area of distribution details is great. Beautiful. Good. So what is your answer here? Is it A, are you going to perform? So on examination, multiple excoriation papules and burrows are noted in the web spaces of his fingers. A scabies preparation using a skin scraping from his wrist fails to detect mites, eggs, and feces. What's the most appropriate next step? Looks like the jury is divided on this. So let me give you the right answer. The answer is that you want to repeat the skin scrapings from additional sites, because you did the skin scrapings from a particular site and you didn't get what you were looking for. So a negative scabies preparation does not rule out scabies, as the sensitivity of the test ranges from 46 to 90%. Okay, so repeating the scraping from multiple sites, particularly from burrows or erythematous papules in areas such as the web spaces, flexor wrists, groin, increases the likelihood of detecting the mites, the eggs, or the feces. Remember that you are trying to pick up the mites under microscopy or eggs or feces. So the whole point of this question is that you did the scrapings from one part of the body. You didn't see anything. What will you do next? Just go to other parts of the body. We've already learned the distribution. Go to the next other parts of the body and try to get some scrapings so that you can see it under the microscope, right? That is all that the question was saying. So the question says that, so let's summarize the question. The question is like, the patient has come. You've done skin scraping from just one part. of the body. You didn't see anything. You are still suspecting that this patient has scabies. What should you do? All you need to do is look for other places where the patient has the scabies distribution and do the skin scrapings as well, and then check it out. And we've already done it. We've already learned that it can be on the elbow, it can be in the axilla, it can be in the groin, So take samples from all these places. The reason why you may at times take a sample and not see what you are looking for is because the sensitivity of the test is very wide, from 46 to 90%, right? So if you don't find it in one place, look in another place and you may find it. All right, good. So why are the incorrect answers incorrect? Perform a skin biopsy of the affected skin. Skin biopsies are not typically indicated for diagnosing scabies and are reserved for cases where other differential diagnosis must be excluded. Number 2, conduct an adhesive tape test. The adhesive tape test is an alternative to skin scraping, but is less sensitive. So look, if the skin scraping test, the sensitivity was 46 to 90%, then the adhesive tape test, the sensitivity is even lower, okay? And it can be considered if repeat skin scrapings are not feasible, all right? So like in children or those unable to tolerate it, that is when you do the adhesive tape test. But remember, adhesive tape test, the sensitivity is lower than the scraping test. The scraping test, the sensitivity is 46 to 90%, right? So if you have adhesive tape test and you have the scraping test, the best test for you to do will be the scraping test, right? Now, what about perform a blood test for eosinophilia? Remember that eosinophilia may be seen in patients with crusted scabies, but is non-specific, because remember that the question was, what is the most appropriate next step in confirming the diagnosis? Confirming. So we are looking for, how do we confirm scabies? So it makes E wrong. Diagnose clinically and start treatment. You want to confirm the diagnosis. The question is asking you, even though in regular cases you don't want to always confirm before you start treatment, but this particular question is asking you that, please, how do you confirm it? And you don't confirm with eosinophilia. Eosinophilia may be present or may not be present. And even if there's eosinophilia, there are other causes of eosinophilia. So eosinophilia alone does not confirm scabies, right? And then diagnose clinically and start treatment. While clinical diagnosis is appropriate when history and examination strongly suggest scabies, confirm the diagnosis with repeat scrapings is the next best step if you're uncertain, right? Good. Let's go to the next question. I'm very happy about these sessions, frankly, because these sessions are helping us to learn tricks on how to answer MCQs. Okay, so you have a 45-year-old woman who presents with intense pruritus that has progressively worsened over the past 6 weeks. She has erythematous papules and excoriations on her web spaces, wrists, and lower abdomen. A previous scabies preparation was negative, and her symptoms persisted despite a full course of permethrin treatment. On dermoscopic examination, no mites are visualized. Her 17-year-old son, who lives with her, is asymptomatic but has a history of mild eczema. What's the most appropriate next step in managing this patient? A, repeat scabies preparation from multiple sites. B, start oral ivermectin for both the patient and her son. C, diagnose scabies clinically and retreat the patient with permethrin. D, perform a biopsy of the affected skin to confirm the diagnosis. And E, investigate for hypersensitivity reaction unrelated to scabies. Doctors, share the link with your friends. Please subscribe to the YouTube channel as well. Please kindly do that. Subscribe to the YouTube channel so we can grow it. And the more you subscribe, the more YouTube also makes it, available for other people to see, right? The more you subscribe, the more YouTube makes it available for other people to see. Please, what's the next? What's the answer? So I'm just checking something here. So we are at 1,674 subscribers. I want us by the end of this class, everybody on this class, please kindly subscribe to our YouTube channel. At least this is my service to you. This is also your service to us, so that we can move, the YouTube channel, so that as many doctors can use the resources we have for the Q1 preparation. Okay, please. This is just my little ask for you. So, are you going to repeat the scabies preparation from multiple sites? Are you going to start oral ivermectin for both the patient and her son? Are you going to diagnose scabies clinically and treat the patient with permethrin? Or are you going to perform a biopsy of the affected skin to confirm the diagnosis? Or are you going to investigate for a hypersensitivity reaction related to scabies? And the correct answer is you want to start oral ivermectin for both the patient and the son. So this patient probably has treatment-resistant scabies, right? Potentially due to the incorrect permethrin application and reinfestation from asymptomatic close contact or a high mite burden. Oral ivermectin is effective for resistant cases. So if you have a patient, you treat her with permethrin, it didn't help, you have to go to the next step. Remember, we saw a case of ivermectin being used in the previous lessons we did, and we learned that ivermectin is not your first thing you want to do. So if you try your permethrin and it doesn't work, then that is when you go to your ivermectin. Okay, so oral ivermectin is effective for resistant cases and should be combined with topical permethrin for optimal efficacy. Treat an asymptomatic son is critical, as he could be a reservoir for reinfestation despite a lack of symptoms. Okay, so this is why the wrong answers are wrong. Repeating scabies preparation from multiple sites. Now, while repeating the scabies, the scraping can be useful, prior negative results and the failure of permethrin treatment support proceeding. You've got to move on to the next step rather than repeating the same diagnostic tests, right? So I'll leave this here and then we'll move on to the next one. So let's summarize it. Treatment of resistant scabies. Why do patients develop what we call resistant scabies? Number one, improper treatment. That is, they may not apply the permethrin well. Reinfestation from untreated close contacts. So like that patient's son, he may not be symptomatic, but he may be a reservoir or resistant to first-line treatment. How do you treat resistant scabies? Combination therapy with oral ivermectin and topical permethrin. Okay, all close contacts, symptomatic or asymptomatic, should be treated simultaneously. And how do you diagnose it? You have to have a high clinical suspicion. So even if the patient has negative scraping results, we learned that if you want to confirm, then you have to scrape other places and then check under the microscope. But even when you think this is scabies, but the patient did not respond to permethrin, you've got to move on to the oral ivermectin. And don't forget to treat close contacts as well. Okay? Now, confirming scabies. We've already talked about it, but we are trying to wrap everything up. The diagnosis of scabies is based on detection of mites, eggs, and fecal pellets. And the definitive diagnosis is skin scrapings, which you can analyze under the microscope. Presumptive diagnosis is based on consistent history and physical exam, especially if microscopic examination is not feasible. We've already talked about classic symptoms, classic scabies symptoms. We've talked about crusted scabies symptoms, which is also seen in immunosuppressed patients, right? And then the examination of the mites. Let's take our time and look at that quickly. You do skin scraping, okay? And then you scrape the lesions using the number 15 blade or disposable curette. And it can be a bit painful. And you can apply some mineral oil to the blade to help remove the mites and the debris, okay? And you examine the sample under the microscope and you're looking for mites, you're looking for eggs, you're looking for fecal pellets. And the common areas or the common sites for scrapings can be in adult, you see finger webs, you see wrist, you see elbow, like you can look at the elbows, you can look at the axillary, you can look at the groin, you can look at the breast and the feet. For children, check the palms, check the soles, and check the torso. Okay. Alternatively, you can use the adhesive tape test. But remember that I told you that the adhesive tape test is not as the adhesive tape test is not as sensitive as the skin scraping. Okay. And the adhesive skin tape test is used for children or patients who are unable to tolerate scraping. And what about dermoscopy? Dermoscopy uses a handheld device to visualize and mite in burrows, or you see what we call the delta wing sign. Okay. And burrows are more easily seen, especially in crusted scabies. And the limitations of dermoscopy is that it has lower specificity, and it is difficult in darkly pigmented skin of the people, like people who have dark skin like myself, right? So always think about this. I'm going to do my skin scraping, I'm going to check under the microscope. That's what you need to know for the QE1. And remember that I told you about laboratory tests. Laboratory tests are not routinely used to diagnose scabies. Okay. In crusted scabies, however, you will see, if you should do a laboratory test in a patient with scabies, you will see eosinophilia and you will see elevated IgE levels. So please, doctors, please get this right. You don't use laboratory tests to diagnose scabies. However, if you have a patient with scabies and you do your laboratory test, you will see eosinophilia and you will see elevated IgE levels. All right? Good. Doctors, please, how has it been so far? Please, I have a question. How has it been so far? So that you don't get confused, right? Next best step after you do topical permethrin, use your oral ivermectin. Why? Because the patient may develop treatment-resistant scabies. And when you are doing your oral ivermectin, don't forget to still do your topical permethrin. Do you need laboratory tests to confirm scabies? No. However, if you should do your laboratory test, what will you see? You will see eosinophilia, you see high IgE levels. What about in people like children? If you try your skin scraping test and you don't see, nothing comes out, what do? You want to scrape a different place. If only you want to confirm your diagnosis. Your diagnosis, you are going to check for you're going to check for mites, you're going to check for their eggs, you're going to check for their feces under the microscope. Hello, remember that skin tape test or the tape test is not as sensitive as the skin scrape test. Usually do the skin tape test in children and people for whom you may not be able to go back to do the scrape test again. Forget about the dermoscopy and those are another level. For QE1, remember skin scrape test, remember your tape test. Doctors, are we good? Dr. Sabine says things are much clearer. Dr. Isaac says very informative. Dr. Noel says expository. Powerful. Powerful. I like that word, expository. Powerful. Now, let's go to differential diagnosis. So, quick ones. Differential diagnosis of scabies. The first one you have to know is atopic dermatitis. Atopic dermatitis will present with chronic itching, dry skin, and inflammation. Usually in patients with atopic dermatitis, they may have an underlying history of asthma or they may have other allergies, okay? No burrows or no intense nighttime itching. Usually it affects flessural areas. So that's atopic dermatitis for you. So if I give you this spot diagnosis, what's your diagnosis? Boom, you should be able to tell me. Number 2, contact dermatitis. So it looks like this patient wore a ring on the finger and has developed, contact dermatitis, right? There's usually reddening, swelling, and itching triggered by an irritant or allergen, okay? And it is limited to areas exposed to irritants. So this patient might have worn a wedding ring or something, a ring, and the skin reacted with that. So remember, eczema or atopic dermatitis is one of the differentials. And how do you differentiate that? Number 2, contact dermatitis. It occurs in an area where there was an irritant to the skin, right? It is limited to areas exposed to irritants, and no household contacts are affected in contact dermatitis. But in scabies, there are household contacts, right? What about nummular eczema? That's also a differential. Round, coin-shaped, itchy patches on the arms, the legs, and the trunk. Another thing, how do you differentiate that from scabies? No burrows or no secondary household involvement. All right, doctors? Okay, I'm just talking about them. What are arthropod bites? Maybe, you know, an insect bite. You know, isolated pupils. You see them, it's isolated at the bite site alone. There's no burrows, no, and it often resolves without treatment. But scabies will not resolve without treatment, right? And then dermatitis herpetiformis is another differential. It presents as an intensely itchy vesicle on the forearms, the knees, the scalp, the buttocks. Patients with dermatitis herpetiformis, the next thing you want to check for is gluten sensitivity. All right? And if you do skin biopsy, it shows granular IgE deposits in the dermal papillae. However, in scabies, if you do skin scratch test, you rather see eggs, you see fecal matter of the Sarcoptes scabi, right? Hello, doctors, please. Hello, 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 hello. You guys are sleeping on me. Hello, hello. Is that okay? Are we breaking it down? We are looking at the differentials quickly so that you don't confuse anything with the differentials, right? Can I move on, please? Can I move on? Okay, good. Okay. And then another differential is bullous pemphigoid. In the early stages, it is itchy, urticaria-like lesion, tense bullae on the red or normal skin. The diagnosis, skin biopsy will show linear IgG or C3 deposits. But in scabies, you see on the microscope, you see the fecal matter, you see the mites, you know, you see their eggs. But in bullous pemphigoid, if you do skin biopsy, you rather see linear IgG and C3 deposits at the basement membrane. Okay, good. What about psoriasis as a differential diagnosis? Well demarcated plaques with silvery scale. Always look for that word. Silvery scale. Silvery. Look for that word. Right? In psoriasis, there are no burrows, there are no mites on skin scraping. All right? Psoriasis. So doctors, we are even using this question to, or this differential diagnosis, to do a quick review of dermatology. Right? Quick review. What about seborrheic dermatitis? Yellowish, greasy scales in the sebaceous rich areas like the face, the scalp, the chest, right? Differences from crusted scabies, no fissures, no maladrous crusts, right? And then we also have delusional parasitosis. Remember in the causal conditions, when we started the MCC objective review, it talked about the fact that patients can have delusional parasitosis. The patient thinks he has something on the skin. Delusional, right? False belief of infestation, despite the fact that there's lack of evidence. Delusional parasitosis. And the difference between delusional parasitosis and scabies is that there are no mites, there are no eggs, right, on examination. And in a patient with suspected delusional parasitosis, you need to do psychiatric evaluation. Right? Doctors, hello, hello, hello. Please, can we move on? Can we move on? Can we move on? Can we move on, doctors? Can we move on? Delusional parasitosis as a differential, right? So, let's do some questions. So, you have a 68-year-old man living in a long-term care facility diagnosed with crusted scabies. He presents with widespread scaling, crusting, and fissures, particularly on the hands and the feet. His caregivers report similar pruritic rashes among other residents. The patient is treated with combination of oral ivermectin and topical permethrin. What additional measures should be implemented to control the spread of infestation in his institutional setting? Remember that this was one of the key objectives. What to do, like public health related stuff, right? So this is where dermatology meets approach to pruritus, and then meets public health as well, right? So isolate the patient, clean and vacuum the rooms, and treat all residents and staff simultaneously. B, restrict visitors to the facility and monitor new cases among the residents. C, provide prophylactic oral ivermectin to residents only. D, remove bedding and clothing for 48 hours before reintroducing them into the facility. And E, delay treatment for asymptomatic individuals until confirmed scabies is diagnosed. What's the correct answer? Are you going to go for A? Are you going to go for B? Are you going to go for C? Are you going to go for D? Or are you going to go for E? Doctors, please, let's participate. And please, hit the like and subscribe button. Kindly make sure that you subscribe to our YouTube channel. Doctors, please help us to grow this channel for your own sake. So you can see the algorithm, you can see the algorithm very well. And then it also helps to spread the good news of MedCognito. We are doing a great work for the IMG community. Please share it so that as many doctors as possible can take advantage of this and can learn from our platform. Okay, we want to serve as many people as possible. So what's the correct answer? The correct answer is what? A, you want to isolate the patient, clean and vacuum the rooms, and treat all residents and staff simultaneously, right? In cases of crusted scabies in institutional settings, aggressive measures are necessary to control the infestation. Remember, for somebody to develop crusted scabies, it could be that the patient is an elderly patient, and it could be that the patient has an underlying immunosuppression. And remember that this is a long-term care facility, right? There are other elderly patients there who may have underlying immunosuppression. So if you don't deal with it quickly and then it spreads like that, there's trouble, right? These include isolating the affected patient to prevent transmission, thoroughly cleaning and vacuuming the environment, and treating all residents and staff regardless of symptoms to prevent reinfestation. Hello, hello, hello. Good. So I think we all got that one right. A, I'll just leave this here so that you can take your time and review. Like restricting visitors to the facility. Remember that restricting and monitoring for new cases is not sufficient in an institutional outbreak, especially with crusted scabies, where mite burden is very high, right? And also remember that we learned that casual contact is not what leads to the transmission of scabies, right? What about provide prophylactic oral ivermectin to residents only? You need to provide the prophylaxis not to residents only, but both residents and staff, right? Because the staff, they go from resident room to the other room, right? If you've been to a long-term care facility before. So if they come in contact with this particular index patient who has the scabies, and we don't deal with them as well as the residents, we are in trouble, right? And then remove bedding and clothing for 48 hours before reintroducing them into the facility. Scabies mites cannot survive off the human body for more than 2 to 3 days. But removing items for 48 hours is not as effective as washing and drying them with heat, which ensures eradication of the mites, right? And delay treatment for asymptomatic individuals until confirming scabies is diagnosed. That's also wrong. Asymptomatic individuals in close contact with crusted scabies cases should be treated simultaneously. All right? Good. So next question. A 32-year-old pregnant woman in her second trimester presents with severe pruritus that is worse at night. Examination reveals excoriated papules and burrows on her hands, wrists, and abdomen. A scabies preparation confirms the presence of mites and eggs. She's concerned about the safety of treatment during pregnancy. What's the most appropriate treatment for this patient? So we are looking at scabies and pregnancy. A, oral ivermectin. B, topical permethrin. C, topical lindane. D, benzoyl benzoate lotion. And E, observation until after delivery. So how will you treat a pregnant patient with scabies? Are you going to give an oral ivermectin? Are you going to give topical permethrin? Are you going to give topical lindane? Are you going to give benzoyl benzoate lotion? Or are you going to observe until after delivery? So you see, doctors, it's good to look at every topic from different angles, right? Because if you are looking at scabies from all these angles. Scabies in pregnancy, scabies in an institutional patient, scabies in an immunosuppressed patient, scabies in a child, right? That's what we've done. And we've just merged the management principles into all of them. Okay. So it looks like a lot of people went for topical permethrin because Dr. Sabine went for that, Dr. Chizoba went for that, Dr. God's favor, Dr. Paramitha also went for that, Dr. Sylvie also went for that, and the correct answer is topical permethrin. Topical permethrin is the first line treatment for scabies during pregnancy due to its high efficacy and minimal systemic absorption, making it safe for both the mother and the baby. Permethrin is preferred over oral treatments and other topical options due to its favorable safety profile. So now, why are the rest wrong? Oral ivermectin is not recommended during pregnancy due to limited safety data. Okay. B, topical lindane is contraindicated because of its potential for systemic toxicity, neurotoxicity, particularly in the infant. What about benzoyl benzoate? Even though it is effective, it is not the preferred treatment in pregnancy due to concerns about systemic absorption, right? So lindane, don't go there. If the patient is pregnant, don't give lindane, please. And what about observation until after delivery? No, scabies requires immediate treatment to prevent complications and reduce transmission, right? Because like in pregnant patients, they need people to take care of them, and you don't want the people to run away. Okay, so delaying treatment would prolong symptoms and increase the risk of spreading the infestation. Okay, next question. You have a 78-year-old immunocompromised man with a history of lymphoma. He presents with diffuse scaling and thick nails. He reports minimal itching. Skin scrapings confirm a high burden of Sarcoptes scabies. He started on combination therapy with oral ivermectin and topical permethrin, which I think is a good thing to do for him. After 5 days, he develops fever, generalized erythema, and hypotension. What's the most likely cause of his clinical deterioration? A, toxic shock syndrome. B, Jarisch eczema reaction. C, sepsis due to secondary bacterial infection. D, Stevens-Johnson syndrome. And E, hypersensitivity reaction to permethrin. Immunosuppressed patient, elderly patient, lymphoma, diffuse scaling, crusting and thickening nails, minimal itching, skin scrapings confirm a high burden of Sarcoptes scabies. Sarcoptes scabies. He started on combination therapy with oral ivermectin and topical permethrin. 5 days, develops fever, generalized erythema, hypotension. What's the most likely cause? I see there's a battle between C and B. C and B. Some are saying Jarisch eczema reaction. Others are also saying sepsis due to secondary bacterial infection. The answer is a Jarisch eczema reaction. Remember, Jarisch eczema reaction is a systemic inflammatory response caused by the release of antigens from the dying mites following effective treatment. And this reaction can mimic sepsis. And that is why a lot of doctors went for the sepsis. And how does Jarisch eczema reaction present? Presents with fever, erythema, and hypotension, and is most common in cases of crusted scabies. Remember, this guy has immunosuppression and he developed crusted scabies. So now let's look at how to differentiate Jarisch eczema reaction from sepsis, because we said that Jarisch eczema reaction can mimic sepsis. Now let's go there. Let's look at the sepsis. All those secondary bacterial infections are common in crusted scabies. The acute onset of the symptoms immediately after treatment initiation suggests a Jarisch eczema reaction rather than sepsis. And why? Because the organisms are dying and they are releasing those antigens into the body. Okay. Now I have a question. Which other condition can give you Jarisch eczema reaction? I want to know. Which other condition, when you start treatment, can lead to Jarisch eczema reaction? Can you tell me? Jarvis eczema reaction. Please, who can help me? Jarvis eczema reaction. Which other treatment can lead or can give you Jarvis eczema reaction? I see some answers. Lyme disease. Beautiful, 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 beautiful. Lyme disease. Beautiful, beautiful, beautiful. So, Lyme disease. Beautiful. Syphilis as well. If you are treating a patient with syphilis, or they can develop Jarvis eczema reaction. So please note that very well. Lyme disease, relapsing fever. It can also lead to that, right? Lyme disease. And of course, someone said lice infection. Leptospirosis as well as yours, right? And then Treponema pallidum subspecies as well as brucellosis, okay? And then tick-borne relapsing fever. And usually, how will Jarvis eczema reaction present? Fever, chills, headache, myalgias, okay? Exacerbation of skin lesions. And they can also present with hypotension in severe cases. So it looks very similar to sepsis, but looking at the clinical context, the patient started treatment, the mites have started releasing their antigens, the patient developed the fever, skin reaction, and then hypotension. Jarvis eczema reaction, please. Jarvis eczema reaction. Q1 is going into deeper waters. And so we need to go into deeper waters. And that is why we are doing what we are doing today, doctors. Doctors, that's why we are doing what we are doing today. So summary point, Jarvis eczema reaction is triggered by the release of antigens from the dying mites after treatment, common in crusted scabies due to high mite burden. And it presents with fever, erythema, and hypotension. How do you manage a patient with Jarvis eczema reaction? Give them supportive care. That's number one, including hydration and antipyretics. Don't give any other thing. Just give them some supportive care. Doctors, so in the same way that we need to give supportive care to patients with Jarvis eczema reaction, please give some supportive care to MedCognito by subscribing right now. Subscribe. Today's class has been awesome. Okay, so treatment overview of scabies. Let's go. First, you want to eradicate the mites, the eggs, and then the fecal matter. Number two, you want to manage the pruritus, okay, by relieving the itching. Number three, you want to manage the complications. So where you treat infections or secondary issues, and you want to treat the close contacts of the patient as well. And then environmental measures, you want to stop the transmission. So let me take it again. If you have a patient with scabies, doctors, what are your steps in management? Number one, eradicate. So you want to do things to eliminate the mites, the eggs, and the fecal matter. Number two, manage the pruritus, relieve the itching. Number three, manage complications. So if there are any complications, and we learned some complications, secondary bacterial infections, post-streptococcal glomerulonephritis, chronic urticaria, right? Also treat their close contacts to prevent reinfestation. And then environmental measures. All right? Okay, good. Okay. So what are the treatment options? First, if it's classic scabies, remember that we said that we will start with permethrin. It's the most effective and safest for classic scabies, right? You want to apply from the neck down, and you want to leave it for 8 to 12 hours, and then you wash it off. Other topical medications can be benzoyl benzoate, but remember, benzoyl benzoate is less effective. Number two, in pregnant patients, you want to be very careful with benzoyl benzoate because of its absorption potential, right? What about precipitated sulfur? It's safe in pregnancy but has an unpleasant odor. What about topical ivermectin? There are alternatives but no proven superiority over permethrin. What about lindane? Lindane is out of favor, and especially when you see lindane in a pregnant patient, please run away, because lindane is contraindicated in pregnancy, right? Please. What about oral therapies? We've learned today oral ivermectin is an alternative for non-pregnant adults who prefer oral treatment, but usually it is not a first line. If you want to give ivermectin, make sure you've tried your permethrin first. And when are you going to try oral ivermectin as well as your first line? In patients who cannot tolerate or apply topical therapies. Oral ivermectin is very important in patients with crusted scabies, so patients with immunosuppression like HTLV1, HIV, lymphoma, right? Patients on immunosuppressive medications, patients who have also tried, like elderly patients who have developed crusted scabies or Norwegian scabies, right? And the dosage is typically repeated after 7 to 14 days. What about so back to classic scabies, which we see in like the regular scabies we see. Topical permethrin is the initial therapy, and oral ivermectin can be used as an alternative. What about crusted scabies? So crusted scabies is the severe form, right? Which is seen in immunosuppressed patients. Topical permethrin plus oral ivermectin, and the duration depends on the severity. How do you recognize cure and treatment failure? Success, treatment signs. How do you see that the treatment you are giving is successful? The skin lesions will resolve, and nighttime itching will improve within 1 week. Some people can have persistent pruritus. Usually it can be normal for up to 4 weeks after treatment. And what are the causes of persistent symptoms? So you have a patient with scabies, but the patient has persistent symptoms. What are the causes? It could be that there's treatment failure. It could be that there's contact dermatitis from the medication you're applying, that's the permethrin. It could be that the patient has developed reinfestation, or it could be that there's an incorrect diagnosis. You are rather confusing one of the differential diagnoses of scabies for it, and that is why the patient has developed persistent symptoms. What about treating close contacts? Because you are going for a QE1. Remember, you have to always learn, not in isolation, but learn scabies and public health implications, right? So the patient has developed the scabies. What do you do for other close contact? Treat all asymptomatic close contacts simultaneously to prevent spread. And symptoms may take weeks to appear, so proactive treatment is key. All right, doctors, are we all good? Are we all good? Please, are we all good? I want to know, are we all good? Today, I'm sure you've been scabies out. You've been scabies out. Scabies, if you don't need to read scabies again. Scabies should be on your fingertips. So what are the environmental measures? Scabies might survive only 2 to 3 days off the human skin. So wash their clothing in hot water and dry on a heat cycle, right? And dry cleaning or isolation items for 72 hours can work as an alternative. Why? Because the scabies mites can only survive 2 to 3 days off the human skin. What do you do to the rooms of the patient? Clean and vacuum the areas used by the infested individual, especially for crusted scabies. And what about patients in institutions? Doctor, this doctor is very funny. She says something. She says, I am itching right now. Because we did scabies. Okay, so what about patients with in institutions? What do you do to them? Essential in nursing homes, hospitals, or prisons to stop outbreaks. You have to act promptly. Okay, crusted scabies, high priority due to high transmission risk. Why? Because the mites are a lot in there. Doctors, this is it. Thank you for your great participation in the class. Thank you for your great participation in the class. I think we nailed scabies today, right? This is how we do it in MedCognito. We nailed scabies today. So remember tonight, if you want to join the dermatology class just to seal everything, you can join us. You can join us. Tomorrow we have med drills in ethics. On Thursday, you have hematology and oncology for QE1. If you're also interested in our narcotic class, cardiology and respirology will come on January 21st. TDM will restart, I think, in March, not February. If you need help with MMI, it's ongoing, reach out. If you need help with CAMS and personal statement, reach out. If you need help with one-on-one interviews, reach out. Okay? So many testimonials. Remember, you can get our QE1 package for just $2,199, or if you even want it for just a month, you can get it for $450. So doctors, you can reach out to us. Take advantage now. Now we also introduced a 3 months package. So 1 month goes for just $450, 3 months is $1,350, and then 6 months is $2,199. We've made it available so that everybody, even if you want access for just a month and do some quick reviews on some specific topics, you can still get that, right? That's MedCognito for you. That's MedCognito for you. Doctors, tomorrow we're going to have the drill, med drills, 3 hours, ethics, sharp, sharp, sharp. We're not going to waste time at all, okay? So please, do your best to register if you are not in MedCognito, or you can just get access to the 1 month package, and you get access to tomorrow's med drill, you get access to the replay of the last med drill, you get access to everything in MedCognito for just $450 for a month. Doctors, reach out right now. If you're interested in any of these, or you want to talk to me, this is my phone. Some people have already started texting me on WhatsApp. Please reach out right now. +1 306 891 5649. +1 306 891 5649. My number is also scrolling at the bottom of the screen. Okay, reach out right now. Right now. Just send me a WhatsApp. Just send me a WhatsApp. I'll also add you to our private our WhatsApp group as well. So just send me a WhatsApp right now. Join me. Let's start studying. Register right away. Use today's class to cement your dermatology concepts. Tonight to be a banger. It's going to be everything dermatology should know for your MCCQE1. Thank you very much. It's always a pleasure to study with you. It's always a pleasure to help you in your preparation. Join us. Let's prepare effectively for this exam. As always, your friend, your brother, your companion in MCCQE1 preparation, Dr. Bruni and the MedCognito team. All the best. Good day. Have a wonderful day. Bye-bye.